Thank you, everybody, for joining us today. Our speaker today is John H. Tucker. John Tucker has maintained a private practice in Erie, Pennsylvania since 1982. He's a graduate of the University of Pittsburgh School of Dental Medicine. Dr. Tucker has a special interest in the treatment of obstructive sleep apnea. As a diplomat of the American Board of the Dental Sleep Medicine, he is exceptionally qualified to manage the serious problem with oral appliance therapy. Dr. Tucker was named one of the best sleep doctors in 2012 and 2013 by the Sleep Review Journal for sleep specialists. He has been actively treating patients in the tri-state Erie area for the past 10 years. Dr. Tucker works directly with sleep physicians and sleep centers to ensure that his patients receive the most positive treatment outcome possible. He founded Erie Dental Sleep Therapy, LLC in 2007. Erie Dental Sleep Therapy, LLC became the 8th AADSM accredited facility in June of 2012. Erie Dental Sleep Therapy, LLC was also named one of the best sleep facilities in 2012 by the Sleep Review Journals for sleep specialists. Dr. Tucker is passionate about education and educating the dental profession in treatment of the PAP, intolerant obstructive sleep apnea patient. He has presented approximately 1,700 hours of continuing education on treating the PAP intolerant patient with oral appliance therapy nationally and internationally over the past 6 years. Dr. Tucker has also published numerous articles regarding oral therapy for RSA patients that are unable to tolerate PAP therapy. And without further ado, Dr. Tucker.
Thank you, Victor. I am very thankful for the opportunity to present this program on behalf of Space Maintainers Lab. Thank you to Scott and Rob Weiss. And Space Maintainers Lab is my go-to laboratory, and they are a great partner to assist in treating our PAP intolerant patients. So today's topic is dental sleep medicine in your practice. And why do you want to even consider being involved with dental sleep medicine? And the first thing I think that we need to look at and understand is that approximately 50% of those patients that are diagnosed with obstructive sleep apnea are unable to tolerate PAP therapy, positive airway pressure, or CPAP, continuous positive airway pressure. In the center of the screen, you'll see a patient with a ResMed full face mask. And this patient sought treatment with us because she was intolerant of this therapy. This is a very serious disease. It has multiple associated comorbidities that can be life-threatening. So where do we fit in? We fit in by providing oral appliance therapy for the PAP intolerant patient to assist them in having a better quality of life, assisting them in regulating their associated comorbidities. I've been doing dental sleep medicine for approximately 10 years, and I've identified some major roadblocks that circumvent dentists from becoming implementing dental sleep medicine into their practice. And the three roadblocks are, first and foremost, we all know no matter what vertical it is that we want to add to our practice, be it implants, be it perio, be it endo, if we don't have our team completely on board and have a unified message, whatever we try and add, whatever that vertical in dentistry is, it's going to fail miserably because we have to have a unified message from all team members. The second issue is obtaining a diagnosis. And many of us have struggled with trying to establish relationships with the sleep community, the sleep physicians, and having them assist us in getting patients that we are suspect of having obstructive sleep apnea and are undiagnosed, we have struggled with being able to get those patients into the system, getting them a diagnosis, and even worse yet, once they do have a diagnosis, they don't come back to us for treatment. And the last thing, and probably one of the most important, is getting paid. And I think for most of the people that are watching this webinar, if they had a choice of doing a 3-unit bridge versus an oral appliance for the CPAP intolerant patient, they would choose at this point in their career, unless they've been seasoned in dental sleep medicine, they're going to choose this 3-unit bridge. Why? Because they know exactly how much they'll be reimbursed by the insurance company, the dental insurance company, and exactly how much the patient's copay is. So these are the 3 roadblocks that I have personally identified, and we will touch briefly on these roadblocks and how they can be broken down to assist you in implementing a successful dental sleep medicine practice. So a little bit about me. I'm located in Erie, Pennsylvania. My practice was established in 1948 by my father, Paul. I went to the University of Pittsburgh, graduated in 1982. I maintain a general practice with emphasis on prosthetics, implants, and obviously dental sleep medicine. I do practice every day, except the days that I'm on the road and speaking. So I have a complete understanding and knowledge of all the issues we all face every day in a general practice, trying to make sure that we have a unified message with our team, trying to make sure that the practice is successfully moving forward. Once again, as I stated, one of the primary roadblocks with whatever it is in dentistry that we want to add, whatever vertical it is, unless we have the entire team on board, it's going to fail miserably. We have to have that unified message with whatever we are trying to implement in our practices. So our practices are a little bit different. My practice is different than it was 10 years ago. All of a sudden, we're seeing, excuse me, holes in our hygiene schedule, and some days our hygiene schedule looks like a piece of Swiss cheese. So I know what you all go through. I know what it's like to run a private practice, and I, once again, provide general dentistry as well as implants and dental sleep medicine on a daily basis. So let's look at the dental practice. One of the things that we all pride ourselves in with our practice is being able to successfully schedule our patients twice a year for hygiene recall and hygiene maintenance. It's no secret that if you have a very strong hygiene department, that is the backbone of the practice. Successful hygiene department means successful practice. The other thing is, most of us are very proud of the amount of time that we spend with our patients. We love to discuss patients' treatment needs and spend time with them, as well as the hygienist being able to spend quality time with our patients. We see in the medical profession that many times appointments with a PCP, primary care physician, is limited to, excuse me, 6 to 7 minutes. And I would think that most of you in your practice, your hygiene department spends anywhere from 40 minutes to an hour with our patients, and they are in a prime position to talk to the patients about their airway. This is all about airway health. This is not about 2 pieces of plastic. We're talking about treating the patient because they have some type of airway issue, and we'll get more into that. Let's look at an article that was published in Chest. I like to cite the literature, and when we read sleep literature, we need to look at the N, meaning the number of people that were part of the study. This is an excellent study with an N of 1,506. The Berlin questionnaire is a subjective questionnaire regarding sleep, and what they found was that 26% of those 1,506 respondents were at high risk of having obstructive sleep apnea, with more males than females. So what does that mean to you in your private practice? Let's assume we have a healthy private practice of approximately 2,100 active patients. That would mean that there are 546 patients at high risk of having obstructive sleep apnea in your practice right now that have not been diagnosed. So let's translate that to some easier math. That means that 1 in every 1 of 4 patients that walks through your door has undiagnosed sleep apnea. And I think we're in the perfect position to be able to be part of the screening process for those patients that are undiagnosed. And once again, hygiene team members are the key individuals to be able to start a conversation with the patient regarding their airway, assuming that they have a message that is valid and it is a unified message for the office. Let's look at some other literature. This is work by Terry Young et al. It states that 93% of women and 82% of men with moderate to severe sleep apnea syndrome have not been clinically diagnosed. So there are a lot of patients out there that have not been diagnosed with obstructive sleep apnea. So let's get down to some brass tacks, and let's think about, is this really worth it for you to add to your practice? Dental sleep medicine is a very hot topic in dentistry today, and there have been a lot of mistruths spoken about dental sleep medicine, and that it's an instant quick hit. So let's think about, why should you add this to your practice, and is it worth your time and effort? Because if you're like me, I think dentists, we all have toys in the closet, meaning we've all purchased or bought into something that has not been successful, and it sits in the closet. And one of the reasons is, once again, is because we don't have our team behind us and we don't have that unified message. And one thing that I think that we all fail to realize is, what's our return on investment if we get involved with something? So I hate to talk about money, but let's get real and discuss what the possibilities are for you in adding dental sleep medicine to your practice. So based on the article in Chest, 26%, or 1 in 4 of your patients are at high risk of having obstructive sleep apnea. As we said before, that's approximately 546 patients. If you look at the literature, and we'll look at that shortly, the industry standard is pretty much 50% of the patients that are diagnosed with obstructive sleep apnea are intolerant to PAP therapy, once again, positive airway pressure, and CPAP is the other term. So that would mean 273 of those 546 patients would require an oral appliance. So if you look at 273 of your patients, I'm going to use realistic EPA numbers of approximately $2,500 per appliance. You can see what your net would be there. We also need to have some type of imaging, radiographs. If you have CBCT, that would mean that you would do 273 CBCTs, and at approximately $350 per scan, you can see the number there. So I think you can agree that it's definitely worth it, and it would be a great adjunct to your practice. But I'm more about the patient than I am about the money. I know we don't need to be altruistic, but I think once we treat the patients for the right reasons, that we will be successful based on treating someone the way we would want to be treated ourselves. Let's look at the correlation between sleep and obstructive sleep apnea. I'm not going to go through the whole process of sleep staging and sleep architecture. That's for a different time. This is just to have you get an understanding of oral appliance therapy and its role in the treatment of the CPAP intolerant patient. This is Dr. Dement. He's a wonderful individual. He is known as the father of sleep medicine. As you'll see, he's an MD, PhD, and Dr. Dement founded the world's first sleep laboratory at Stanford University. This is a quote by Dr. Dement, and you can see that he states that for generations, our profession has looked in the mouths of countless number of patients with sleep disordered breathing without knowing of the disorder. And that is so true. And the next comment that he has is that many times we're the only healthcare practitioners to look in the oral cavity. And I'm not sure why that happens, but I know that when I go to my personal primary care physician, rarely does he look in my oral cavity. I don't know if that's because he knows I'm a dentist and he feels that's my wheelhouse, so to speak. But I've asked many people at our programs the same question and pretty much get the response that very few of the primary care physicians are actually looking in the patient's mouths. Now, when you involve the ENT, that is absolutely different because they do a very comprehensive exam of the oral cavity. So dental sleep medicine is where dental implant dentistry was 30 years ago, and that's my opinion. I started with my first implant course in September of 1982. I became a diplomat in the International Congress of Oral Implantology and became very, very active in the implant arena. I think dental sleep medicine is where we were back in the early 80s. The difference between dental sleep medicine and dental implants is that dental sleep medicine can change someone's life. It can change the quality of their life as well as their life expectancy. So for me, it's a very exciting time for dentistry. The fact that we can work with our medical peers and colleagues to be part of the treatment equation for those people that are suffering from obstructive sleep apnea and are unable to tolerate CPAP therapy. This is a great place for our profession to be. Let's look at what happens with sleep, and more importantly, I like to look at sleep deprivation. I think if we look at sleep deprivation, we will understand the importance of healthy sleep. On the left of your screen, you're going to see many of the associated comorbidities, and we've all known, we're seeing more and more in the literature as well as in the media, the link to ADD and ADHD in children, the link with diabetes, decreased heart rate variability, heart disease. You can see everything on the right side of your screen. And then I like the one that says tremors and aches, and that makes me lead to thinking about those patients that are diagnosed with fibromyalgia, and those poor people suffer greatly. And I think it's interesting, I've yet to meet a patient that reports of having fibromyalgia that has never had a sleep study. So that's something to think about. Let's dive into the literature a little bit more. And you can see at the top of the screen what happens to the body. If you look at the lifespan for a rat, it's normally 2 to 3 years. Once you sleep deprive the rat, they died within 11 to 32 days. So I guess there must be some correlation between healthy sleep and having a healthy life. Great study that came out in Sleep in 2012. a health imperative, and we'll see once again that there are a lot of Americans that suffer from a chronic sleep disorder that leads to poor health. Approximately 1 out of 3 people sleep less than 7 hours a night, and we can see that that has negative effects on the body. And I like to go right to the bottom line where it says disordered or deficient sleep results in ill health or death. So the purpose of these slides is have you understand how important healthy sleep is and to assist you in understanding our role as dentists to be able to provide treatment for those patients that are CPAP intolerant. So let's talk about what obstructive sleep apnea is, and let's talk about some of the negative effects that it has on the body. We're talking about the upper airway, so we're basically, this disease affects from the nose to the base of your throat. So when we have complete obstruction of the airway, that's an apneic event. A partial event is hypopneic event. You can see that it leads to hypoxemia, hypercapnia, microarousals, oxidative stress increases, as well as sleep fragmentation. All of those have very negative effects of every end organ of the body. You can see that there are also important mediators cardiovascularly and neurocognitively, as well as a metabolic risk. This says that 23% of women and 49% of men were found to have moderate to severe obstructive sleep apnea. Obstructive sleep apnea is also independently associated with everything that you see on the screen here. These are all the associated comorbidities that affect these individuals that have obstructive sleep apnea. And that is where our treatment for the CPAP intolerant patient can have a positive impact with an oral appliance in assisting them in all their associated comorbidities. This is a great study. David Gasol, who is current president of the American Thoracic Society, publishes a tremendous amount of literature regarding obstructive sleep apnea. And this study looked at a very large nationwide database. In fact, the N was 3.4 million patients. The cohort included 1.7 patients that had obstructive sleep apnea and 1.7 million patients that were matched controls. And what they were looking at is what type of burden of these associated comorbidities were placed on these individuals. In this screen here, you can see that the red dots represent women that have obstructive sleep apnea, and the blue dots represent men that have obstructive sleep apnea, and then the controls listed below. So you see everything from the type 2 diabetes, the arrhythmias, ischemic heart disease, stroke, hypertension, depression, and CHF. And then if you look to your right, there's the odds ratio of having those comorbidities as they are adjusted for age and sex. So once again, I love this statement that came out of this article. They said that it was a multifaceted end organ morbidity burden. Once again, every end organ of the human body is affected in a negative way by obstructive sleep apnea. Great study that came out in NIH News, April 8th, 2010, that talked about sleep apnea and the risk of stroke. Stroke is the #2 cause of death worldwide. And we can see that when we have sleep apnea, that we're at increased risk of a stroke, 2 times at risk for stroke in males, 3 times with moderate to severe obstructive sleep apnea. And this is one of my favorite slides. It's the first time there was a link between sleep apnea and increased stroke in females. And you can see the middle of the screen is comparable to adding 10 years to a man's age, and that they were even at risk with relatively mild levels of sleep apnea. And unfortunately, I have seen this happen to more than one individual in my life, patients as well as family members that have had undiagnosed sleep apnea, and unfortunately it has led to a stroke. And I think if you talk to anyone as a loved one that suffered from stroke, it's not a wonderful experience, as it puts a tremendous amount of burden on the family as well as the patients suffering. I put together this slide that would kind of summarize for you all the effects of obstructive sleep apnea and the associated comorbidities. So you'll see at the top center of your screen everything that's associated with the cardiovascular system, and below that we see 92% chance of having a stroke, the obesity, the diabetes, the snoring, the cost, sexual dysfunction, nocturia, which means getting up in the middle of the night to use the restroom. Once again, 1 in 4 Americans. Lots of depression is associated with this disease, and there's a tremendous amount in the literature that talks about once the airway is cleared and the obstructive sleep apnea is under control, that depression is treated successfully. We see GERD, and we also see daytime sleepiness associated with this disease. Let's talk about snoring. We all know somebody that snores. There's not a person that I know that doesn't raise their hand and says they know someone that snores. I fly a lot, and I will tell you this, there are a lot of people that snore on a plane. You can see that the fact that a snoring person, we're going to see that there are issues from a health standpoint regarding snoring. We all know what it is. It's the vibration of the back of the throat. Any noise heard during respiration while the individual is asleep is considered an indication of some sort of problem with the airway. This is work done by Victor Hoffstein, who states that snoring is the cardinal symptom of sleep apnea. Now, it's interesting, once you start to treat these patients, I've never treated a patient that's come into the office that says, I snore. Their comment always has been, my bed partner constantly is elbowing me. In fact, there's actually an article in the literature about elbowing patients and their correlation with undiagnosed sleep apnea. But just remember, you are not treating the patient, you're treating the bed partner, because no one complains of snoring if they live alone, and that's something that you need to pay attention to. There is a risk factor for snoring for hypertension, angina, and cerebral infarction. Lots of people snore, and guess what? Once you treat the husband, the next thing you're going to notice is that he is making comments that now he notices his wife snores, so it's just not men. And the other thing that I want you to pay attention to is the fact it's just not overweight people. I have a lot of friends that are skinny and are mega snorers, so please don't get caught in the trap of just thinking it's the obese male that has a neck size greater than 18. There was an excellent study done and published in Laryngoscope in 2014 by Dr. Robert Deeb out of the Henry Ford Center in Detroit, and it talked about snoring in the carotid artery, and the comment was made that snoring is just as bad for a patient as is smoking. So that's an interesting fact that they correlate snoring with smoking, and it's a great article, and I would recommend that you take the time to look that one up and read it, and you might want to share that with your cardiologist. But when we treat somebody for snoring or obstructive sleep apnea, we want to make sure that we involve the sleep world and the sleep community before we get started with treatment. This is very, very important for all of you to understand. And I see this a lot, and I think that there will be some issues with this in the future. Please, please, please do not treat a patient for snoring unless you have a diagnosis. Let's touch on that briefly, and what does that mean? That means the patient is either a primary snorer and does not have obstructive sleep apnea, in which case you could treat them just for their snoring because there is no obstructive sleep apnea. So we do have a diagnosis, no obstructive sleep apnea, primary snoring. You also need to know if the patient has obstructive sleep apnea. So if they have obstructive sleep apnea and they're snoring, then you're going to be treating them for both the sleep apnea as well as the snoring. So once again, please do not treat a patient unless you have a diagnosis, and we will talk more about that briefly. Let's look at kids. Kids should never snore. They should not have any noises. You'll see that there is a correlation between the snoring child and healthcare services and visits to the hospital, respiratory issues. Interesting, in the literature, they're talking about how the diagnosis and management of children with obstructive sleep apnea and how they should be treated. In my generation, adenotonsillectomy was done on a routine basis. Then the pendulum swung the other way, and adenotonsillectomy was not done on a routine basis. You'll see here, last bullet point 3, that it is recommended as the first-line treatment of patients that have adenotonsillar hypertrophy. So what is the moral of the story? Make sure that when you're looking at your children, that in your practice, that you're looking at the tonsils. And if they have grade 3, grade 4 tonsils, make sure you ask mom or dad if they snore, because kids are not supposed to snore. Let's quickly look at a great article that was published in the New England Journal of Medicine back in 2013. It's called the CHAT study. You can see that the N was great, and they divided pretty much the group into half, early adenotonsillectomy, and then what they called watchful waiting. They did use sleep studies and assess them, and here's what they found. I won't read through this whole slide, but what they did is they compared the watchful waiting group with the surgical group, and the main point I want you to take from this is that there is evidence of beneficial effects of early adenotonsillectomy. So once again, if you are treating children in your practice, please look at their airway and look at their tonsils, and if there is an issue, my recommendation would be that you would get them to an airway-friendly ENT that understands the implications of the airway and the tonsils obstructing the airway. So let's look at the sleep apnea, what are the symptoms that are associated with sleep apnea. Well, we have EDS, excessive daytime sleepiness, the snoring, the gasping or choking. Typically, it's a bed partner that will comment on the snoring and the gasping. Those patients that report frequent morning headaches. There is a correlation between fatigue, automobile, and occupational accidents, and we've seen that in the media with some of the tragic accidents that we've seen. And once again, I mentioned depression earlier. There's obesity, the neck size. We talked about decreased sex drive, the impotence, bruxing, and GERD. Please don't get stuck in the trap. I want to reiterate that it's just not the obese male that is a snorer. you need to focus on those patients that are skinny that snore because they may have an airway issue as well. It's just not the obese public. One of the things you can start to do immediately in your practice is to look for patients that may have an issue and are undiagnosed and do not even know that they have an airway issue, is look at their health history and their medications, because you'll see on the screen here that these are all the associated comorbidities that go along with undiagnosed and untreated obstructive sleep apnea. So you can even pull your charts the night before, have your team members go through the health histories, identify those patients that you feel that may be suffering from an airway issue, and that would lead into a discussion about perhaps getting them into some type of a diagnostic procedure to see if they do have an airway issue, such as sleep disordered breathing or obstructive sleep apnea. So the way that we used to get the diagnosis was an attended overnight sleep study that was usually done at a sleep center, sometimes a hospital. They're called polysomnograms or PSGs. And that diagnosis of obstructive sleep apnea must be made by a board-certified sleep physician in your state. As dentists, we are not legally allowed to diagnose obstructive sleep apnea. It is totally up to the board-certified sleep physician. A primary care physician cannot diagnose obstructive sleep apnea. So once again, board-certified sleep physician is the only way that the patient can obtain a diagnosis. This is what a PSG looks like. This is one of my dear friends that happens to be a physician, and there are 18 to 21 leads that go from your head to your toes. You can see the respiratory belts around his belly and his chest, and the box that he's holding in his left hand is positioned at the side of the bed, and they tuck you in and say, have a great night's sleep. And oh, by the way, they also videotape you. So should you have to get up in the middle of the night to use the restroom, the box has to go with you. But times have changed as far as the diagnostic protocol goes for obstructive sleep apnea. And the majority of your medical insurance companies are now asking for an HST. HST stands for home sleep test. So they want to see that happen prior to an attended overnight polysomnogram. And if they can obtain the diagnosis and there are no major associated comorbidities, that's the way it's done. So on the left, you can see a report that was generated by the ResMed Apnea link, and then on your right, you will see the diagnosis that was given by a board-certified sleep physician. And there are companies available that can do this for us, such as sleeptest.com. They send the ResMed Apnea link directly to the patient. You don't touch anything. They do a 2-night study, and it comes back with a report and a diagnosis from a board-certified sleep physician. But once again, remember that diagnosis must come from a board-certified sleep physician in your state. PAP therapy, continuous positive airway pressure. It's a vacuum cleaner in reverse. It has nothing to do with oxygen. It blows air and pneumatically splints the airway open. It was invented in 1981 by Dr. Colin Sullivan out of Sydney, Australia, and it still is considered to be the gold standard. Now, adherence, this is where it gets kind of tricky. Depending on what literature you want to quote, it's anywhere from 29 to 83%. And if you remember, as I started this webinar, we used the term 50% of those patients that are diagnosed with obstructive sleep apnea are intolerant of this treatment. That's where we come in with our oral appliances. That's how we're going to treat the CPAP intolerant patient. But once again, before you start oral appliance therapy for any patient, you must have a diagnosis from a board-certified sleep physician in your state. And you also need to make sure that they're CPAP intolerant. I do not treat the CPAP tolerant patient. If they are good with their CPAP and they're compliant with their CPAP, I have lots of patients in my practice that love their CPAP. Please leave those patients alone, and I would advise you not to be on the bashing CPAP train. Leave the CPAP tolerant patients alone. There are plenty of other patients that need our assistance that are not able to tolerate that therapy. One of the reasons I love Space Maintainers Lab is because they have a multitude of appliances that you can choose from. They just don't have one appliance. There are many different appliance designs. Space Maintainers Lab can assist you in selecting the appropriate appliance for that patient. I get asked the question all the time when I speak, what is the best appliance? And my answer is the one that will treat that patient. So check with Scott Weiss and their incredible team, and they can assist you in selecting an appliance for your patient that is CPAP intolerant. Please remember, this is medicine. This is a medical disease. Obstructive sleep apnea is a medical disease. My line is a medical disease with a dental solution. So if we look at all the different designs of appliances, there are over 153 FDA cleared designs. Oh my goodness. Where do we start? And if you're like me, most of us just tell me what appliance to use, tell me where to set the bite, and I'll be good to go. Well, we can't do that because, as I said, there's not one specific appliance that will treat each and every patient. Once again, Space Maintainers Lab has a variety of designs, and they can assist you in selecting the right appliance for your patient. Now, interestingly enough, I still get comments that, oral appliances don't work, the medical community has never blessed it. Well, that is not right. And back in 2006, the American Academy of Sleep Medicine made the statement that we can use appliances for the patients that have mild to moderate sleep apnea or prefer them to CPAP, do not respond to or not appropriate candidates for or fail treatments with PAP therapy. So that has been 11 years ago that we were given the go-ahead by the medical community to be part of the treatment team for the CPAP intolerant patient or the patient that prefers an oral appliance over CPAP. These guidelines were updated in 2015, and I want to go to point 1 that talks about prescribing an oral appliance for the primary snorer. That is now part of the guidelines, and go to number 3.3, that the sleep physicians prescribe an oral appliance rather than no treatment for the patients with OSA who are intolerant of PAP therapy or prefer that alternative therapy. And the other thing is this, the comment that I get from many sleep physicians is that they don't get follow-up from the dentist that they refer the patients to for treatment. So please make sure that you are doing adequate follow-up with the sleep physicians or whoever referred you that patient. And all you need to simply do is send that physician a copy of the patient's soap notes. So therefore, you have kept the physician in the loop of the treatment progress of the patient they referred to you for treatment. So one of the things I think is really, really, really important for us to remember is that dental sleep medicine is a journey. And the reason I bring this point up is because there are so many things that I read on the internet and see published that shut off your general practice and just flip the switch and have a overnight success with dental sleep medicine. And I got a letter this week from someone that attended my program back in 2011, and I have never subscribed to this mantra of it being a light switch. I think it's a rheostat, and he shut down his practice and tried to set up a dental sleep medicine practice, and it was not very, very, very successful with it at all. So let's think about anything that we've done in our practices, whatever vertical it is that you've added it. Let's focus on implants. If you've added implants to your practice, has that not been a journey? Has that not been a rheostat? It's not been a light switch. Anything that we have tried to implement and add to our practice has taken time and effort, and it's been a journey to get where we are today in our practice. Dental sleep medicine is no different. It's not a quick hit. It's not a quick hit for making lots of money. It's a journey, and it's a very, very valuable journey, and it's one of the most incredible things I have done in my 38 years of being involved in this profession. So here's what you have to understand. We have a lot of patients that need you. 1 in 4 of the patients that are walking through your door are undiagnosed with obstructive sleep apnea. We have to have a diagnosis before we can treat them. But you have to figure out if you're willing to be part of this change, and are you going to be willing to assist this patient in having a better quality life. We saw that the April 8th, 2010 article from the NIH News that talked about adding 10 years to someone's life. So I'd like to invite you. We have started some new programs with Tucker Educational Excellence. We offer a 2-day program entitled Dental Sleep Medicine. It's not difficult, it's just different. We'd love to have you attend one of our programs, and we also offer various other educational opportunities. You can, we call it In the Wild, where you can come visit me at my office and shadow me and watch how I treat patients. There's the opportunity for me to come to your office and assist you and your team in treating patients in your practice. And the other one is Climb to the Summit, the Ultimate Journey, which is a year-long commitment. It's over 40 hours of continuing education credits. We also have 2 videos that stream live. There's a 2-day live recording with the title of Saving Lives, and that's me doing the 2-day program, which is a great review if you've been to one of the programs, and it's also an asset for your team members. It's an 8-hour video, and it's one of those things that your team can watch it and have the experience of attending one of our 2-day programs. And then the other video is we recorded the entire in-office treatment protocol of me treating a CPAP intolerant patient with an oral appliance, and it goes through every visit from the initial consultation to the titration protocol to the final follow-up. And you can find all that information at tuckerEducationalExcellence.com. Please feel free to visit our website and see the 2-day programs that are available and the schedule for this year, as well as all our other continuing education offerings. So I am really blessed to have some incredible partners that have been with me on this journey. This is a recent photo of one of our two-day programs, and I call it the Dream Team, because without all these gentlemen, I would be lost, and the only person that we're missing is Scott Weiss. And Scott, we certainly did miss you. So we have, starting on your left, Mr. Rob Suter from VATEC. Next person is Mr. Al Simon, who used to be the Director of New and Exclusive Products for Henry Schein. Al retired from Henry Schein in October and joined me in starting Tucker Educational Excellence, and Al is the Director of Strategic Planning for Tucker Educational Excellence, as well as a partner. And then we have my dear friend, Mr. Elias Kalanzis, who is the founder of OSA University. And there is a forward webinar on the SML website that talks about the importance of team engagement. And that's what Elias has come up with, is a online university to educate your team in how to speak to your patients so that you have that unified message. Next is Randy Kern, and Randy Kern is Director of Pristine Medical Billing. They focus on medical billing for oral appliance therapy, and Randy is one of the most honorable people in the industry. He's of great moral character and does an excellent job ensuring that you have positive results in billing the patient's medical insurance. And then next to me is Mr. Ryan Javenbach, and Ryan is head of sleeptest.com, and sleeptest.com can assist you in obtaining a diagnosis if you're unable to work with your local sleep community, which I encourage, but that is no longer a roadblock. So I hope this webinar has been beneficial to you. I've certainly enjoyed putting it together. If you have any questions, please feel free to reach out to myself. We've listed the website once again for you to look up details. If you have questions, you can go to info@tuckereducationalexcellence.com, or you can call 855-MY-GUIDE. I want to once again thank Scott Weiss and Rob Weiss and the entire amazing crew at SML Lab for the opportunity. I want to thank them for being an amazing partner in this journey, and I wish you all well. Thank you once again.